Hey everyone, welcome back to Block On. Great to have you here. Today's video features my lecture on regional anesthesia for spine surgeries, a topic I presented in the IDRA 2025 online teaching module. Let's get started. I bring warm greetings from Ganga Hospital, Coimbatore. Let me begin with a brief declaration. All photographs and data have been appropriately cited in my slides and are accessible via the QR codes I have embedded in each slide. Most of the illustrations and videos are my personal drawing and creations, and the necessary consent has been obtained from the patient and the volunteers. In this session, we will try to explore the anatomical foundation, mechanism of action, and the clinical evidence behind erector spinae plane block and the T-lip block, thoracolumbar interfacial plane block, and obviously the other paraspinal blocks in spine surgeries, while also discussing the common pitfalls and how to avoid them. So, Akhil sir, can I have the first poll, please?
Yes, Dr. Tuhin. In this, the first question was, have you ever performed or observed an erector spinae plane block for any surgical procedure? So for the yes, we had 54 respondents, and for no, we had 7 respondents.
Okay. Majority of the participants today have performed or observed erector spinae plane block. So that makes my job actually easier. So how and who are sorted out? We will focus here on the other questions and what to do and what not to. So if you have attended my last class on brachial plexus block, we have discussed about the spinal nerve when it is coming out after the intervertebral foramen and the course of the ventral rami. Now we have to focus on the dorsal rami. What happens to the dorsal rami when it comes out of the intervertebral foramen? As you can see here, after coming out, it is coursing on the posterior aspect and branching out in the intermuscular groove. And it usually divides into a medial branch, which is also supplying the facet joint and the lateral branch. And in lower thoracic and the lumbar region, it has one extra intermediate branch. Now, there is one more important nerve, that is the recurrent nerves, recurrent sinovertebral nerve or recurrent meningeal nerve or Lusker's nerve, that is originating from the ventral rami, not the dorsal ramus. After coming out from the ventral ramus, it is re-entering into the intervertebral foramen and supplying the meninges as well as the posterior and anterior part of the peripheral part of the vertebral body as well as the disc. Dorsal rami, according to the level of its innervation, it divides into several branches which runs into the intermuscular groove and ultimately supply the skin, subcutaneous tissue and the posterior muscles. So now, is the innervation pattern same for all the dorsal rami? So the answer is no. There are 31 pairs of dorsal rami. C1 is also known as the suboccipital nerve. The C2 is greater occipital nerve, and the C3 is the third occipital nerve. Three of them form the cruvel plexus. This is also known as the posterior cervical plexus. We have seen the anterior cervical plexus in superficial, intermediate, and deep. This one is the posterior cervical plexus, which are formed by the dorsal rami, and they subsequently supply the area. Now, L1, L2, L3 dorsal rami form the superior cluneal nerve. S1, S2, S3 form the medial cluneal nerve. Now, what happens to the inferior cluneal nerve? Inferior cluneal nerve is not formed by the dorsal rami. It is coming from the posterior cutaneous nerve of the thigh, which is forming by the ventral rami. If we divide this area into the level above T6 and below T6, the cutaneous supply by the dorsal rami is coming from the medial branch above the T6, whereas below the T6, it is coming from the lateral branches. So these are the dorsal rami without cutaneous supply, and all the dorsal rami usually gives medial and the lateral branches, except these two, they are coming out as a single branch. And the lumbar dorsal rami and some of the lower thoracic, which has three branches, medial, intermediate, and lateral. Okay, so if we draw the dermatomal mapping or the sensory mapping of the area supplied by the dorsal rami, we will get this kind of picture. The green shaded area is the area of our interest, which are supplied by the dorsal rami from head to glute region. So now what happens to the muscles? The muscles of the back, usually we can divide it into superficial, intermediate and deep part. The superficial part, that is connecting the limbs with the body. The intermediate part usually involves in thoracic cage movements, and today our area of interest is the deep part. Here you can see the erector spinae muscle, that is actually a group of three muscles: iliocostalis, longissimus, and the spinalis. All of them have their separate names at different regions. And please remember, multifidus is not a component of the erector spinae group of muscle. If we draw the thoracolumbar fascia is dividing the deep part from the intermediate and the superficial part. I can make your life simple. That is, the everything below the thoracolumbar fascia is supplied by the dorsal rami. As simple as that. No need to remember individually. So the erector spinae muscles, that is our area of interest today, that is supplied by the dorsal rami. As we have understood that we have three muscles which are forming the erector spinae group, from lateral to medial: iliocostalis, longissimus, and the spinalis. Now, other than the dermatome and the myotome, we have osteotomes innervation also, that I have already discussed, that is supplied by the dorsal rami as well as the part of the ventral rami. And we can see when there is instrumentation of the spine, that is the pedicle screw inserted through the pedicle, and ultimately it penetrates through the posterior cortex of the vertebral body and reaches inside the vertebral body. In this area posteriorly, that area is covered by the dorsal rami and posterior part of the vertebral body, where, if you remember, that recurrent meningeal branches come, which is coming from the ventral rami. So to complete the analgesia from block, we need to block the dorsal rami as well as the part of the ventral rami, or the specifically this branch of the ventral rami. Today we are discussing about the erector spinae plane block, which according to the area of spine surgery, we can divide it into cervical, thoracic, lumbar, and sacral. Why I have put a different color for cervical and sacral, you will subsequently understand. And another block, that is the thoracolumbar interfacial plane block. All these comes under a single umbrella now, according to the latest Delphi consensus, that is the paraspinal block. Let's understand the erector spinae and the thoracolumbar, how they are working. While doing erector spinae block, we are hitting the transverse process and depositing the drug. As simple as that. In T-lip block or thoracolumbar interfacial plane block, we are inserting the needle in between multifidus and the longissimus muscle in this area and depositing the drug. So that drug is blocking the medial nerve. Perfect. Then it can spread towards anterior and block the other branches of the dorsal rami. So that is the way it is working. It may or may not block this part. So that is why this pairing was reported after its description by Hand et al. In 2015. So Dr. Ki Jin Chin, he proposed that we can give a subcutaneous infiltration along with this thoracolumbar interfacial plane block. So that will cover almost all the branches and it will provide a good analgesia. Then in 2017, another technique was described that was named as the modified thoracolumbar interfacial plane block, or the lateral thoracolumbar interfacial plane block. Here we are depositing the drug in between the longissimus and the iliocostalis muscle. So as I told, nerves are traveling in between two muscles because the lateral branch mainly covering the dermatomal area. So our target should always be to include the lateral part also. The researcher have noticed that there is a good analgesia with this one, but it was not proposed because of this anatomical difference. When you do the conventional thoracolumbar interfacial plane block, their needle direction was medial. The drug can spread towards the neuraxis. So that is why it was proposed that this direction, the needle will be from medial to lateral, these complications can be avoided. The anatomical discrepancies was not described in their paper, but I feel this is the reason why modified has a better analgesic effect than the conventional one. Now, when we deposit the drug in the erectospiny plane, it has at least 5 to 6 spread patterns. So, number one, it can spread posteriorly towards the muscle, which is the most common one. Number two, it can spread towards the anteromedial area, and through the intervertebral foramen, it can reach up to the epidural space and as well as the subarachnoid space. Then number three is again anteromedially, you can go to paravertebral spread. Then laterally, it can spread between the thoracolumbar fascia and the erector spinae or the QL muscle. The fifth one is the craniocaudal spread to cover the multiple vertebral levels, and the sixth one is the systemic absorption. Epidural spread or the spread towards the lumbar plexus area was responsible for the quadriceps weakness when this erector spinae plane block was used in patients for hip analgesia. As you can see, 30 ml of 0.2% ropivacaine was used, and they've also noted the tibial is anterior weakness. So lumbosacral spread was noted here, because if you look at the anatomy, there is no specific anatomical barrier like that we have in thoracic area, that is superior costotransverse ligament. Here it is open, so drug can travel if you deposit higher volume of drug. We noted transient paraplegia in two patients out of the retrospective analysis of 316 spine surgery from 2017 to 2020. 20 ml of 0.25% bupivacaine was used with dexamethasone. So there was transient paraplegia after extubation, it was noted, and almost it took 4 to 5 hours from the placement of the block. Both the patients recovered fully, motor first and then sensory, which looks like a neuraxial spread. The MRI was completely normal in post-operative period. This kind of complications we have to keep in mind when we are thinking about erector spinae plane block with higher volume or higher concentration. It is possible. So when we are depositing the drug in the erector spinae plane, that is above the intertransverse ligament here in this region, how that drug can travel towards the thoracic paravertebral space. So it has to reach to the retroacetial space first. So this is the intertransverse ligaments. So around the ligament, there are spaces through which it can access the retroacetial space. And from that space, it can reach up to the thoracic paravertebral space. It's look like a very long shot, correct? But with the current understanding of the thoracic paravertebral anatomy, which was described in 2021, we can think that it is possible because we have a medial and the lateral slit of the acetyl through which, if the drug has reached here, some amount of the drug through these slits can involve the ventral rami also and reach the paravertebral space. So maybe it is not a big amount of drug in erector spinae, but when you are doing the intertransverse process blocks, or like for example MTP blocks, mid transverse process to pleural block, there you are depositing the drug here which has direct access to this one. And there is also one costotransverse space or costotransverse foramen that is also connected to the paravertebral space, as you can see here, this one that is connected to the intertransverse tissue complex and through the ACTL to the paravertebral space. That's how the drug deposited in the erector spinae plane can reach these two areas. Is in every patient it is reaching like that and blocking the ventral rami? The answer is no. We don't know in which patient it will reach. But because it is not always reproducible. Here you can see in 12 healthy volunteers, the authors injected 20 ml of 0.5% ropivacaine at T5 transverse process, and they have noticed the cutaneous sensory loss. These red colors are the cutaneous sensory loss area, and more of this declination area, cutaneous sensory declination, almost T4 to T11 when you are doing the injection at T5. But if you see the lateral extension of this sensory declination, that is maximum up to the posterior axillary line. Only one patient it crossed the posterior axillary line, and in every cases there is no sensation decrease in the anterior chest wall or lateral chest wall. So mostly it involved the dorsal rami and not the ventral rami here. And in this study, most of the time patients were in supine or the sitting position. Now, what if we make the patient prone after giving injection over a period of 30 seconds and 30 ml of 15 ml of 0.75 with 15 ml of drug, total volume is 30 cc. The authors noted paravertebral space sprayed almost 96 to 0.5%. So the 86 patients were divided into three groups. One group patient was in lateral position, another group patient was supine after the block, and another group patient was in prone for 30 minutes. So this is the total percentage I'm talking about. The intercostal space sprayed was around 94%, neural foraminal sprayed was 77%, and the epidural space was noted around 24%. There was not clinically significant difference, but you can see the prone position is always ahead of the other two positions. So maybe the muscle contraction, because patients are awake, muscles contraction, or the negative pressure during respiration, or the gravity and the injection speed, as 30 ml of injection was completed within the 30 seconds, they helped for the drug injected in the erector spinae plane to reach the intertransverse tissue complex, and then the next step, that is the paravertebral space. The other factors, as I have mentioned, the injection site, LA volume, speed of injection, and the block needle placement may affect the spread of the erector spinae plane block. The authors concluded that prone positioning after erector spinae plane block significantly enhanced the local anesthetic spread. The gravity plays a substantial role, and sensory block of the anterior and the lateral abdominal wall and chest wall was again highly variable. So, erector spinae plane block is not a silver bullet. We need to understand that every block has its own place. Dr. Sishi sir was telling that is a rib block. Dr. Manoj Karmakar has mentioned, but I don't agree with the rib block. Every block has its own indication, and with our knowledge, with our understanding, we can decide where to do this block and how much to expect from effect from that block. So on one hand, erector spinae is being considered as the plan A block, and on the other hand, we are questioning about its mechanism. So if you look at the mechanism of the facial plane block, each facial plane block usually act by three different mechanisms. One is the direct local action by bathing the terminal nerve endings, the indirect distant action by spreading towards the parent nerve or the main nerve, and the third one is always a systemic absorption and analgesia, like we do lignocaine infusion for analgesia. Moving towards the lumbar erector spinae for the lumbar spine surgery. These are the various spine surgery we do at our hospital. For simple discectomy, like microscopic discectomy or endoscopic discectomy, we usually don't use the erector spinae plane block if it is a single level. But for other surgeries, we are usually using the erector spinae plane block. Now, in this study, with when erector spinae was compared with the local anesthetic infiltration, it was seen that total tramadol consumption, the first six are VASCOR, number of rescue analgesia and nausea vomiting incidents were decreased in the erector spinae group as compared to the local anesthetic infiltration. But you can notice here the erector spinae plane block was performed pre-operatively in awake patients, and the wound infiltration that was given after the surgery. There was a considerable gap between the two interventions. So this was not a balanced comparison. But the VASCOR was comparable and there was no significant difference even after that. And this is the only meta-analysis where erector spinae plain block in spine surgery was compared with the control like sham block or systemic analgesia, and they have noticed decreased analgesic requirement and rescue analgesia, incidence of nausea vomiting were decreased, but there was no difference at first analgesic requirement time and the time to ambulate or total length of stay in the hospital. So this can be explained with the spread pattern in the cadaveric study. If you see that with 20 ml volume, the spread is not much. In only L4 level, the injection was performed and the spread was only L2 to L5. When the volume was increased, the drug has reached towards the lumbar plexus. So two cadavers out of 12, they have lumbar plexus spread with the higher volumes. And here, if you see at L4 level, the injection was performed, methylene blue dye injection with 20 ml volume. The dorsal rami were stented, ventral rami were not stented, and the spread here were L2 to sacrum, but not beyond sacrum. And the epidural space here were not dissected, so we don't know whether it was spread to the epidural, but the injection spread was limited to the L2 to sacral area. So the problem with the lumbar erector spine is, as you can see here, the erratic or inadequate spread pattern. It is not that kind of smooth what we observe when we give the thoracic level erector spine plain block. The prone position when we perform the erector spine plain block after induction, that time because of the lumbar lordosis is present and because of the hanging abdomen, the depth from the skin towards the transverse process also increases, and along with that the fatty layer is also increased in abdominal region. So what I have seen is it is sometimes difficult to identify the correct plane and difficult in placement of the needle and difficult to get a good drug spread, especially when novice practitioner is performing. With thoracolumbar interfacial plane block, the same problem exists. Here, identification is further difficult. If you look at the MRI picture, it is very easy to identify the three muscle, multifidus, longissimus, and the iliocostalis, as there is the intermuscular fatty tissue which is hyper intense or bright. We can see it as a bright lines on the MRI films. So it is very easy to identify here. But with ultrasound, it is not that easy to identify the individual planes. Place the probe, just like your neuraxial ultrasound scanning, you place the probe over the spinous process in the midline and then slowly move towards laterally. So what you will get is spinous process, then articular process, and then transverse process. And the muscle which extends from the spinous process to the articular process, that is your multifidus muscle. And the muscle next to it is a longissimus thoracis muscle. Okay. So now here you can see it is still very difficult to identify the correct interfacial plane. So what we can do is we can use some saline to hydrodissect and identify the correct plane, but still there is a possibility of higher intramuscular local anesthetic injection and the LA myotoxicity and subsequent weakness of the muscles. So this is the difference between the intermuscular septum between the longissimus and the iliocostalis. So another problem is the literature evidence. If you look at the literature on thoracolumbar interfacial plane block, out of 53 articles published in the PubMed, almost 16 articles are already retracted because of the data fabrications. So it is very difficult to rely on the published data related to this block. So now this one is why I have included, because this SRMA was already excluded all the retracted articles, but there was a lot of bias, scarce data when it was compared with the LA infiltration. Mainly we get data on the sham block or no block when it was compared. And another important thing is it can be used only for the lumbar spine surgery, maybe 1 or 2 level. We cannot expect more than that because it is a very localized plane block. it is not right to compare the erector spiny with the T-leaf block, but still it was compared in this meta-analysis. We can see erector spiny is obviously a winner. It has less opioid consumption and VAS scores at 1 to 24 hours, but there was no difference in opioid related side effects. I have formulated this table for you. You just can take a screenshot for this. I am not going to discuss about this. This is from the whatever data available on the internet. I have just made it for your exam purpose. Just take a screenshot and read it later. Lumbar erector spiny, as I have mentioned, that spread pattern is not that good, and the thoracolumbar interfacial plane block also is not helping much. So, what would be the solution? Before going into the solution, let's discuss something about the lumbosacral or the sacral spine surgery. So, what we do is here we give sacral multifidus plane block. So, we have a couple of publications from our department where we have used sacral multifidus plane block for the sacral, lumbar, lumbosacral, and the spinopelvic fixation surgeries. So here, how does it help? I call it sacral multifidus plane block, not the sacral erector spiny. Let me come to that first, because here, if you see, we are injecting the drug below the multifidus muscle. Okay, and if you see the three muscle layer here, from deep to superficial, multifidus, longissimus thoracis, and the latissimus dorsi muscle. So, out of those three erector spiny group muscles, so what we have discussed, only the longissimus thoracis muscle left, which is attaching at the S3 or S4 level, but that is also the aponeurotic part. So, there is no point of calling it as the erector spiny because it has nothing to do with the erector spiny group of muscle. We are depositing the drug between the multifidus muscle and the periosteum of the sacrum. So it is the musculo-osseous plane block. So what we do is we place the ultrasound probe over the median sacral crest and get a picture like this, and then we slowly move towards laterally and ultimately reach the dorsal sacral foramina. As you can see here, the gap in between the continuous line, and then again we move back towards the median sacral crest. So in between the median and the lateral sacral crest, we have the intermediate sacral crest where we deposit the drug either out of plane or in plane and hit the bone and deposit the drug. It is quite easy as compared to the lumbar erector spiny plane block. As you can see here, we have seen the dorsal sacral foramina, and now we are in the median intermediate sacral crest and we are depositing the drug. This is, I know it is over again picture. I deliberately did that. Now you can see this hypoechoic area is all local anesthetic spread only. So the three muscles are here, and this entire hypoechoic area is local anesthetic spread. Now this spread caudally, there is a restriction because of the attachment of the multifidus muscle and the longissimus thoracis muscles. Drug will spread in the path of least resistance, that is in cephalar direction, and ultimately block the lumbar dorsal rami. So another variant is you can place the probe in transverse orientation and deposit the drug on both sides by hitting the bone below the multifidus muscle. In one probe position, you can deposit the drug on both sides at S2 level. In this RCT, it was found that it decreases the opioid consumption, decreases the VAS score and number of rescue analgesics, and also improves the patient satisfaction. So what happens is when you do the transverse orientation injection, that has a limited spread towards the S1 to S5. Here you can see when the surgery is limited to the sacral area or the coccyx, that you can think about this transverse probe placement and depositing the drug. Why I prefer the intermediate sacral crest approach is when you deposit the drug, even with the cadaveric study, it was proved that the drugs can spread up to L2 or L3 level. So when you are depositing a good amount of drug, we use 20 ml of 0.2% ropivacaine with 8 milligram of dexamethasone on each side. So that might reach up to, and with our clinical experience also, that reaches up to L2, L3 level and provide good analgesia and blocks the dorsal rami. So the lower lumbar region problem is solved. Now, what we will do for the upper lumbar region, there we use the lower thoracic region like T10, T11 or T12 level erector spiny plane block. So that takes care of the upper lumbar region like L1, L2 up to L3. Our practice of erector spiny plane block is now limited to only specific lumbar region surgery. Suppose the surgery is for L2, L3, L4 or that level. If it is going to be the lower part, that is L4, L5 or L3, we give the sacral multifidus plane block. And if it is involving the L1, L2, we give the T12 or T11 level block. So that takes care. We don't need to give a lumbar erector spiny for this. We have cut down the number of lumbar erector spiny only specific to when it is limited to the mid lumbar regions. And after our publication, this was subsequently published, and they also have found that the lower thoracic level analgesia has good analgesic effect, reduced opioid consumption, and improved postoperative recovery. Coming to the thoracic rectus spiny plane block for the dorsal spine surgery, we mainly use it for the deformity correction like scoliosis correction surgery and fracture spine vertebroplasty or corpectomy, and in some cases of deformity correction where the cosmetic correction is required by doing a costoplasty, there also erector spiny helps. So we don't need to give a separate plane block for that. So what we do is a bilateral, bilevel or multi-level erector spiny plane block. In this study, other than decrease in opioid consumption and decrease requirement of the remifentanil and propofol, there were some important findings. That was, erector spiny group also had lower neutrophil to lymphocyte ratio and platelet to lymphocyte ratio, which are directly related to the attenuation of the surgical stress, and also lowers the surgical site infection and the deep vein thrombosis. Higher the value is related to the increased incidence of surgical site infection and DVT. And the erector spiny plane block also did not affect any intraoperative MEP amplitude. This we have also observed in our clinical practice. A few things we need to consider while doing erector spiny plane block for the idiopathic scoliosis correction surgery. The bumps or the rib hump that obstruct the spread of LA. So when you are planning for the erector spiny plane block, so avoid those bumps either proximally or distal to the bump. You have to do separate injection to get a spread. The pleura is closed on the convex side, and the transducer we have to usually tilt it away from the spinal column, and on convex side it is towards the spine. And single view may not be adequate to know the correct drug deposition area. So what we can do is you can start with the paramedian scan, and then after reaching the erector spiny plane, we can change the view with the transverse orientation and confirm the needle position at the tip of the transverse process and deposit the drug. It may not be easy with higher Cobb's angle and more deformity. So the LA spread convex side usually towards the lamina, and concave side usually our initial ultrasound probe is towards the costotransverse junction or towards the rib. So by changing the probe position, we can confirm the needle tip position, and then we can do. And the number of injections or LA volume is requirement on concave side is more than the convex side. This one we have also reported in adult neuromuscular scoliosis and fracture surgery. This is what I was talking about. Avoid the hump area or the fracture area in this case, and use the proximal or the distal to get a good spread, and depending on the level of involvement or the level of surgeries. So the problems with the thoracic erector spiny is sometimes there might be lamination, as you can see here inside the muscle. If you deposit the drug, you might see there is a good cephalocaudal spread, but that might be intramuscular. So here you can see the entire transverse process and pleura complex is going down, or the erectory groups of muscles are going up. So this kind of movement should happen. Then you can understand that you are in the erector spiny plane. Or what you can do is, as Dr. Madan Narayan suggested, that we can change the probe and identify the correct position of the needle and then start depositing the drug. So, which might help here. Coming to the cervical spine surgery, we are doing the anterior as well as the posterior. For ACDF surgery, we don't use the erector spinae plane block. We either use the local wound infiltration before the incision or the superficial or intermediate cervical plexus block. For the others, what we use, let me discuss. So at the cervical level, we have erector spinae, retrolaminar, multifidus cervicis plane block, and interspinal. What are these blocks? So let me describe, but before that, from superficial to deep, we have trapezius, planius capitis, semispinalis capitis, semispinalis cervicis, and then multifidus. Remember these five layers of muscles. Now, please understand here, after coming out of the intervertebral foramen, the dorsal rami is giving off the medial and the lateral branches. As we have mentioned, lateral branch has no role here, that has role below the T6. And here, the medial branch is important. Medial branch is also supplying the facet joint as well as it is traveling in the intermuscular area and ultimately giving the cutaneous branches. So this green color line you are seeing is the investing layer of the deep cervical fascia, which is investing the trapezius, and anteriorly sternocleidomastoid it will invest. And this pink color line you are seeing is the paravertebral or prevertebral fascia. So, whatever block we are doing here, we are always piercing the prevertebral layer of the deep cervical fascia. Please remember that. Now, coming to the individual block, so what is happening? Erector spinae, we are depositing at the tip of the transverse process. Two problems. One is the transverse process is very, very small. It is very difficult to identify on the ultrasound. And second problem is, as you can see, it is very close to the brachial plexus. So whatever drug you are giving, that might spread towards the brachial plexus. And if you are using higher concentration, higher volume, definitely that will block brachial plexus as well as the your phrenic nerve. So that is why you might be seeing the current publication that erector spinae, cervical erector spinae, or T2 level erector spinae, they are being utilized for the shoulder surgery as a phrenic sparing block. At lower level they are giving, not this level. This is, I am talking about C3 to C6 level. So now the next one is retrolaminar, where we are hitting the lamina and depositing the drug. But this drug is very close to the neuraxis, so it has the potential to spread towards the neuraxis. Now coming to the multifidus cervicis plane block, where the drug is deposited between the multifidus and the semispinalis cervicis muscle. But here the problem is, in this plane lies the deep cervical vessels, which might get injured. And the second thing is, it is still close to the neuraxis. What we are practicing now is the intersemisspinal plane block. The drug is deposited between the semispinalis cervicis and the semispinalis capitis above. So in this plane, the nerve is traveling and then becoming superficial and supplying the skin. As you can see the video here, first we have to identify the five layers of muscle from superficial to deep: trapezius, splenius capitis, then semispinalis capitis, semispinalis cervicis, and the multifidus. So our target area is the between the semispinalis capitis and the cervicis. Please remember, always check with the color Doppler, because sometimes the deep cervical vessels can also travel in this plane. What is our target area between the capitis and the cervicis semispinalis? So here deposit at least 10 to 15 mils of drug, which usually covers from C3 to C7 area, which is adequate for the cervical instrumentation at that level. So now it was a comparison between the intermediate cervical plexus block and the erector spinae for anterior cervical spine surgery. Anterior cervical spine surgery, we are not using erector spinae plane block as I have mentioned because of the fear of the brachial plexus involvement. There was superior analgesia, postoperative analgesia was noted with the erector spinae plane block compared to the intermediate cervical plexus block here, according to the literature. This one is the meta-analysis over the erector spinae. Not many patients. It's very, I mean, small scale systemic review and meta-analysis, but they have concluded that paraspinal block, whichever we are performing, can help in reducing the postoperative pain and opioid usage. The LA volume was used more than 10 cc and it was always bilateral ultrasound guided block. If you look at the cadaveric dye study, the C6, C7 transverse process injection, what I was talking about, that ultimately resulted in C5, C6, C7, C8 block in 100% cases. So this is the ventral rami, not the dorsal one. T1 involvement in 50% cases, C4 involvement in 10%, suprascapular, long thoracic or dorsal scapular in 100% cases, and dorsal rami also involved in 100%. So along with the dorsal rami, these are the problems when we give it for the cervical spine surgery, and there was involvement of the phrenic nerve in 30%. In another two fresh cadaver injections, the injection was performed at the costotransverse junction of the T1, and we get methylene blue dye sprayed along the entire course of the dorsal rami, and also noted the sprayed towards the brachial plexus, extraforaminal and neural foraminal areas, and as well as the epidural space. So that is why we are not using erector spinae plane block, cervical erector spinae plane block at any level. I mean, at cervical or at T1 or T2 level. We have replaced it with the intersemisspinal plane block. Regarding some burning questions, that is whether in anticoagulation patient can we use the erector spinae plane block? Yes, it was considered as the superficial plane block, so we can use it. And in 2024 ASTRA guideline also this was not changed. Then next one is the does it affect the MEP or SSEP monitoring interrupt? So no, that does not affect according to our experience, but provided you should use the not much volume or not higher concentration. Higher concentration we are not using, higher volume we are not using, then we can expect a good spread, good analgesia, and without interfering with the intra neurophysiological monitoring. We don't use the continuous catheter technique in spine surgery. Maybe it helps in other surgeries, but spine surgeries we don't use. Number one is we don't have the evidence so far. Number two is please understand it carefully. We have to insert the bilateral catheter for maintaining a good and post-op analgesia or infusion. Number one is we cannot put catheter near the incision or the wound area. We have to put the catheter distant to it, either proximal or distally. Number two is the facial plane is totally disrupted. So there will be serosanguinous discharge immediately after the surgery. So whatever volume of local anesthetic you are giving immediate post-op period, that will become diluted. So that may not provide a good analgesia at that point of time. So what we will do, we'll give some bolus injection. So ultimately it will accumulate at that area and will later increase the peak plasma concentration. Also, there will be an increase in acute plasma reactants like alpha 1 acid glycoprotein, which will bind to the local anesthetic, and ultimately there will be less immediate effect of the infusion. And there is also a possibility of migration and the neuraxial spread. For these reasons, we don't use erector spinae catheter in spine surgery, but we give single shot block along with the dexamethasone, and then we also cover with the multimodal analgesia. So let's have a look at the prospect guideline. It was last published in 2020. After that, it was not updated. Systemic basic analgesia, yes, we are using this. IV ketamine, no, we are not using infusion, but sub anesthetic dose 10 milligram or 15 milligram that we give during induction time, single dose only. Epidural analgesia, no, we are not using epidural analgesia for spine surgery anymore, not any spine surgery. And opioid, yes, opioid we are using as rescue or low dose of opioid in major spine, complicated spine surgery, scoliosis correction surgery, because we are not running after the opioid free analgesia. We are doing opioid sparing. So opioid crisis is not our problem so far. Erector spiny plain block or any facial plain block or any other block when you are using in the perioperative period, that definitely decreases the requirement of your opioid in the post-operative as well as intraoperative period. This was our latest publication on a 360-degree fusion. So what I'm trying to tell here is you don't rely on a single block. So according to the surgical approach, here there was anterior lumbosacral interbody fusion in supine position from the anterolateral abdominal incision, and then the patient was made prone and the supplementary fixation from the posterior approach was done. So here we combined sacral multifidus plain block along with the ilioinguinal iliohypogastric nerve block in Eichenberger point. So that is a combo block for this kind of surgeries. To conclude, we have explored the evolving role of regional analgesia in spine surgery, understanding the key pain generators which allow us to target them effectively using paraspinal blocks such as erector spiny and its variants. These techniques, when integrated in a well-structured multimodal analgesia plan, it offers a significant clinical benefits from opioid-sparing effects to faster recovery and ultimately leads to patient satisfaction. So that's all from my side. Thank you so much for your patient listening, and to all the candidates, all the best for your exam.